living with Parkinson's, and I just wanted to make sure that you're all seated comfortably, and we'll get through this. It's hard to believe that we're actually halfway through the year, although I'm certainly glad that the winter is behind us and we have several months now of lovely weather to look forward to. Again, if you have any questions during the presentation, please send your question to my CEO, Debbie Davis, at debbidavis@parkinson.ca, or call me at 416-227-3375. I'll try to answer your questions as quickly as possible. Once again, I have chosen a complex topic to discuss with you today, which I have titled, Staying in Hospital, What You Need to Know. If I say something that doesn't make sense to you, which is entirely possible given that I am the messenger, or if you have a question about something that I haven't mentioned, again, please send your questions to the contacts that I've just provided with you. So, we have a lot to cover. Hang on to your hats, and here we go. Hospitals are large bureaucratic institutions which are not well suited to care for the individual needs of people who have Parkinson's. Generally speaking, they are first-rate facilities when it comes to things like performing heart surgery, removing gallbladders, treating kidney ailments, and setting broken bones, things like that. They are, however, frequently ineffective and lack experience in caring for the specific needs of people with Parkinson's who are hospitalized. If you don't take anything else away from this talk today, please understand that most healthcare professionals, including doctors and nurses, actually know very little about Parkinson's disease overall, and certainly won't have any idea that everyone with Parkinson's is different and that you have unique and individual needs. I'd like to share something here about my personal experience with this exact topic that I think will illustrate what I'm talking about. As many of you know, I am a registered nurse, and as such, one might assume that, along with education and training on many topics related to medical conditions, I would have received a good grounding on Parkinson's disease. When I started here, of course, I knew that I would have a steep learning curve after not having worked in that particular field for years. But I quickly realized that I had either forgotten everything, skipped classes on the day Parkinson's was discussed, or that I had had very little education in Parkinson's in the first place during my training. So I looked at my old medical surgical nursing books, and lo and behold, there was only one paragraph on Parkinson's. Now, I admit that that was almost 50 years ago, and we know a lot more about Parkinson's now than we did back then. But the amount of education about Parkinson's that nurses and doctors receive during their training is minimal at best, and is only one of a myriad of conditions that they have lectures on. For all you know, the nurses or doctors you encounter in hospitals may never have seen a person with Parkinson's before. I'm telling you this to help you to understand that from the minute you enter a hospital, whether through the emergency room or through a routine admission for elective surgery, you will have to be prepared to educate, educate, and educate. And don't assume that the healthcare professionals in charge of your care know about Parkinson's. As a result of your incorrect assumptions and their lack of understanding, there are many common pitfalls of hospitalization for people with Parkinson's. As long as you understand this, you can take some precautions to try and avoid some of the all too common problems that can arise. Let's face it, no one likes to have to go to hospital. They are scary and intimidating places at best of times. but of course there are times when they are an absolute necessity. So as long as you're prepared, your hospitalization experience will go more smoothly. The following is a list of commonly held myths or beliefs about hospitals and Parkinson's. Staff will understand all my Parkinson's symptoms. Staff will understand how important my medication is to me and will bring my meds on time, every time. Staff will take my medication from me, either in the emergency room or when I am admitted, but the doctors will write a prescription for all my medications, and the pharmacy will have my prescription medications in stock, readily available. Staff will avoid giving me drugs that are contraindicated for Parkinson's patients. Staff will call my community neurologist and consult with him or her with respect to my Parkinson's management. Not. These kinds of unrealistic expectations are often the reason that things go awry in a hospital setting. You need to take care of your own care by making everyone involved in your treatment aware of your needs. You can't blame people for not trying to meet your needs if you don't speak up in the first place. Parkinson's is not considered to be a life-threatening condition, but having advanced Parkinson's in reality does increase the risk that you will have problems, including things that could be life-threatening, such as a serious fall that includes a break, or infections. The most common reasons people with Parkinson's need hospitalization are elective surgery, which is a planned, non-emergency surgical procedure, such as cataract surgery, or repair of a hernia, for example. Another reason for hospitalization for people with Parkinson's is often a fall, resulting in a fracture, such as a broken hip. Infections, such as urinary tract infections and pneumonia, in particular aspiration pneumonia, are yet another reason, as well as psychosis, such as hallucinations, which usually take the form of the person with Parkinson's seeing things that no one else can see. Also, extreme confusion or a change in alertness can be a reason for a hospitalization. So I've mentioned things like common pitfalls and common problems. It's time I told you what some of these are. The most common problem encountered when a person with Parkinson's is hospitalized involves his or her medication schedule. It wasn't until I started to work here and began to understand the importance of the individual timing of medications for people with Parkinson's that I realized the difficulty this was going to create if someone had to be hospitalized. As nurses, and doctors too for that matter, we are taught that medications are generally ordered to be given at 8 a.m., 2 p.m., 6 p.m., and 10 p.m., or 9 a.m., 1 p.m., 5 p.m., and bedtime. Unfortunately, that kind of routine simply won't work for people with Parkinson's, who may well be taking medications every 2 or 3 hours. And I think many of you have also worked out your own daily schedule to get the most out of your anti-Parkinson medications according to when they work best for you. Also, several of you have found that your medications work better if taken 30 minutes before meals. I'm putting on my nursing cap now, and I can tell you from personal experience that it's really quite unlikely that the hospital staff will be able to deliver your anti-Parkinson's medications on the schedule you have found to be most effective. Also, nurses won't realize that being 1/2 hour too early or 1/2 hour too late can mean a marked difference to someone with Parkinson's. Given the pressures on hospital staff, including the nurse-to-patient ratio, that could be 1 nurse to 8 or 9 patients on any given day, your regime is not likely going to be adhered to with great accuracy. You will no doubt find this fact of hospital life both disturbing and frightening. But rather than becoming increasingly upset with the staff and including the problems that the stress will no doubt make your Parkinson's symptoms worse, it certainly won't endear you to the staff and make you quite unpopular as a patient unless you take a proactive approach. Discuss your complicated medical schedule or medication schedule with hospital staff at the time of your admission, and ask for permission for you and your family to administer your medications rather than relying on hospital staff. Again, don't set up an unrealistic expectation about this, as depending on the hospital policy, this arrangement may not be possible. You must understand that once you are under their roof, they and their insurance are responsible for you and your medications, and they cannot be responsible for the outcome to either you or another patient if your medications are not administered properly. Someone could come into your room, take your medication without your knowledge, and this can create, obviously, a huge issue for hospital administration. Once again, the sooner you start to plan and discuss your needs, the better. So now that you know you might have to turn your medications over to strangers, albeit healthcare professionals, who mean well but don't have a good understanding of Parkinson's, you need to have a plan in place to have the best possible outcome of your hospital stay. With forethought and careful attention to detail, problems can sometimes be avoided, sparing everyone a lot of distress. Here again, knowledge is power and planning is essential. Like any other potential emergency, prepare now. We can provide you with an emergency hospital bag to help you convey important information about your Parkinson's in the event that you need to stay in hospital. It contains information about the importance of getting your medications on time every time, including what benefits there are for the staff if this is handled properly. It contains a poster for your bedside to alert staff to the fact that you have Parkinson's and the consequences to you if you don't get your medications on time, and also includes stickers for your chart to say that you have Parkinson's. It also has hospital admission protocol tips and a medication card. It is essential to have a list of your medications and the medications themselves in their original containers so your hospital physicians and nursing staff can see precisely what meds you are taking, how much you take, and when you take them. Keep this bag in a place that is easy to access, and make sure your family and friends know where to find it. In addition to the other things I've mentioned that you can include in your bag, I would also suggest adding a copy of the Canadian guidelines for physicians, as this will give credibility to what you say. You can call or email us, and we will send you a bag free of charge. Another important part or important fact about going to hospital is that you need to find a friend or a loved one to advocate for you. Someone can take charge of communication with hospital staff during your stay. Your advocate should also make your neurologist aware that you are in hospital, but you need to understand that the only way your neurologist can have any input into your hospital stay is if he or she is invited to participate as a consultant. For example, the doctors at the hospital have to call your neurologist and ask for input. You can request that all your doctors are communicating with each other, but you need to be prepared. This may not happen. I spoke a few minutes ago about choosing an advocate to speak to staff in either the emergency room or to every new medical staff person after that to make sure that they understand your Parkinson's symptoms and how to manage them. This person needs to be willing to go to bat for you and fight for your cause. Someone who doesn't mind being labeled a pain in the neck because it's really not a popularity contest. It's about your quality of life and the quality of the care that you receive. I know the old saying, you get more with honey than you do with vinegar, and it can start out, of course, on a very pleasant note, and should start out on a pleasant note. But sometimes a little acidity and forthrightness is required. At this point, I do need to speak up on behalf of nurses. Not just because I am one, but because you may be admitted to a very busy medical or surgical unit where getting your Parkinson's medications on time may not always be possible. I want to give you an example that happened to me recently that will explain my point. I was assisting with a Get It On Time presentation at a local hospital recently on a busy medical floor where they were treating patients in crisis who had chronic obstructive pulmonary disease, a serious lung condition, as well as other respiratory conditions. During the in-service, one of the nurses spoke up about an all too common situation she sometimes finds herself in. She was on her way to give a Parkinson's patient their medication on time recently because she understood how important it was to the patient with Parkinson's that they get their medication on time. When she passed the room of another patient who she could hear was in severe respiratory distress and was about to go into respiratory failure, a potentially life-threatening problem that needed her immediate attention. By the time she got the patient in respiratory distress stabilized, she was 45 minutes late with the Parkinson's medications. She knew about Parkinson's medications, but there was nothing she could do about it. This was clearly not a lack of understanding on her part. It was her reality, and again, she couldn't do anything to help it. Not to say you shouldn't try to help staff understand, but there has to be some understanding on your part as well about the pressures that staff are under. It is definitely a give and take, compromise situation. Be sure to supply a list of all your allergies to the hospital. They should be asking you about this on admission, but just in case it gets overlooked, you need to communicate this to the staff to ensure you don't receive a medication you are allergic to, such as penicillin, for example, if that could be a problem for you. Another problem that arises when a person with Parkinson's is admitted to hospital is that he or she mistakenly receives drugs that may conflict with your anti-Parkinson medications. I'm going to share some of these contraindicated drugs now, and there is also a copy of these drugs available for you if you wish to have one for your own files. So for pain control, morphine tends to be better tolerated for those with Parkinson's instead of Demerol. Demerol, as well as drugs used for anesthesia, can cause some confusion, which can even take days or weeks to resolve. Control of postoperative confusion should be very conservatively treated, preferably waiting for the problem to resolve itself. And medication to treat the confusion should be avoided if at all possible. But if medication is essential for the patient's safety, for example, then two medications that are safe to use are called Seroquel, that's Seroquel, or clozapine, Clozapine. These two medications, again, are safe to use for anybody who is exhibiting any form of confusion or psychosis. Haldol, and that is spelled Haldol, which is commonly used as a drug for postoperative confusion, should definitely never be given to a patient with Parkinson's. For postoperative nausea and vomiting, medications to avoid are Compazine, Compazine, Stemetil, Stemetil, and Reglan, Reglan, as these medications interfere with the levels of dopamine in the brain, and your Parkinson's symptoms will definitely worsen. You could be given Gravol, either by mouth or by injection, and another medication that is safe to use is Zofran, Zofran. Ensure that your medical team, including your surgeon and the anesthesiology, are aware ahead of time of these contraindicated medications to give them the opportunity to figure out the best way to maintain your schedule before, during, and after your surgery. If possible, also discuss the possibility of having a local rather than a general anesthetic, as this will definitely probably either eliminate or definitely cut down on the level of confusion. Obviously, that is not always possible, but at least you could bring it into the discussion. Whenever possible, especially if a general anesthetic is necessary, surgery should be scheduled first thing in the morning. Also, advocate to be allowed to take your first morning dose of medication with sip of water, even if you're not supposed to take anything by mouth on the day of the procedure. I mentioned that whenever possible, especially if a general anesthetic is necessary, surgery should be scheduled first thing in the morning, but I realized that I didn't tell you why. This is to lessen the length of time that you will have to be without your anti-Parkinson's medications. That's a very important point. As long as your bowel is working normally after surgery, and as long as your swallowing reflex is intact, you should be allowed to start your Parkinson's medications again immediately after surgery. Once again, this is a very important point to get across to the staff in charge of your care. Obviously, in the case of bowel surgery, medications cannot be restarted immediately. So once again, you and the doctors need to discuss a plan in advance about how to manage your Parkinson's medication control postoperatively. Sometimes you could advocate also to, if this is likely to be a possibility, to have a nasal gastric tube, that's an NG tube, inserted prior to the surgery, and that way your medications could be, such as Sinemet for example, could be crushed put into dissolved in water and administered to you through the nasogastric tube until you're able to swallow effectively on your own again. People with Parkinson's are susceptible to some specific medical complications such as delirium, confusion, and aspiration pneumonia post-surgery, as well as blood clots in the legs. But once again, communication with your doctors in charge of your care is key, as if they are made aware of these potential problems, they may allow preventive measures to be taken. When it comes to recovery, it is important that you try to accept the fact that recovery time is generally longer for people with Parkinson's. An extended recuperation time needs to be expected and planned for, as it simply will take your body longer to recover than to the average individual who is in hospital for a similar reason. This is not something for you to become overly concerned about or frustrated with when it comes to this delay. Just plan for it. Also, you will need to work harder than the average patient who has had a similar surgery or medical problem to recover to your previous level of functioning. So by example, if a doctor gives you an estimate of how long it will take you to recover from a typical procedure or surgical operation, they will be basing that on the average individual without Parkinson's, not on you and your Parkinson's. So again, it's important that you understand that a person with Parkinson's may take 2 to 3 times longer. Yes, I said 2 to 3 times longer than a person without Parkinson's. Again, the body just takes longer to adjust. This is, again, nothing to be concerned about, just, again, planned for. I know I sound like the bad news bear today, but it's so important for you to know about all these things so you can plan to be prepared for your hospitalization just in case. So there are just a couple of more things I want to mention before I stop for today. The unfamiliarity of Parkinson's within the hospital staff can create other problems as well as the ones I've already mentioned. In particular, the problems of motor fluctuations and unpredictable ons and offs are often misunderstood by the staff because they don't understand why you can do something one minute and then may not be able to move or even freeze the next. This misunderstanding can result in staff refusing to help you with dressing, showering, or even eating because they think that you're making it up. This again speaks to the need to explain to the hospital staff about Parkinson's, as this gap in their knowledge can result in you not getting the care you need. You will get tired of repeating yourself, but any and all teaching on your part will avoid misunderstandings and hurt feelings. This also applies to things like the wiggly, wobbly, involuntary movements called dyskinesias. I have been asked in several of my in-service presentations, both at the hospital as well as in long-term care facilities, if the patient is just putting those on because they're looking for attention. Nothing, of course, could be further from the truth. I know having Parkinson's is a difficult journey, and just because you have Parkinson's doesn't mean you won't have anything else. I also know that I sound like a broken record that is stuck in a rut, but it is essential to understand again that exercising regularly, helping you to remain physically active as you can each and every day, will help you to recover from whatever other health problems may come along. Last but not least, you must keep in mind that the hospital staff wants you to be well cared for. Always assume wants what's best for you. Teach them, teach them, teach them. Explain the situation in a supportive manner. For example, if you're the advocate for a person with Parkinson's, you could say something like, "Let me explain my husband's situation and give you some literature." Do not accuse the staff of being uncaring. And again, also suggest that they call your regular neurologist, as I'm sure he or she would be more than willing to advocate for you. So now on to some of the questions that I have received with respect to today's presentation. One of the questions involves the possibility of bringing in mobility aids when hospitalized. This is a question from a group that has also included adaptive eating devices, walkers, your own wheelchairs, and more. Thank you to the group that asked this question. It's a very, very good question and not one that I would have addressed as I simply didn't think about this. I may sound a bit repetitious in saying, again, that this depends on the situation, but it really does. The reason that someone is hospitalized, the length of stay, and the hospital's own rules may all have an impact on whether or not to bring in your own mobility aids and adaptive equipment. Keep in mind, before bringing any personal items into hospital, that you are responsible for your own personal belongings. These things can be taken by accident or even purposefully by staff, visitors, or other patients. It is often a good idea, or you may even be required to have your equipment labeled clearly. Do not bring in anything you do not absolutely need, especially for a short stay, as if it is valuable, you need to reconsider your need. If it is a planned hospitalization, it will be important to ask that if you could bring in your mobility aids and other equipment. If part of your rehabilitation is to have you up and walking after surgery, which is very often the case, and also very important for anybody following surgery, but really important for people with Parkinson's, so that you don't have any issues with respect to pneumonia of any kind, you will probably be asked to have your walker brought in. If eating is a concern, it is important to discuss this prior to being admitted, so you have a clear plan in place, so that maybe you could bring in, again, your own adaptive equipment that works for you in order to make eating more easy for you. Keep in mind, it is not uncommon for glasses, hearing aids, and dentures to be accidentally left on a tray, and that the hospital cannot always track back to the owner. So it is important, again, that these be kept in a very safe place, especially if you're going for a surgical procedure. Leave them with a loved one so that you can have access to these directly after surgery. Also, an adaptive spoon is much easier to overlook than you may realize on a busy hospital ward. So again, if you're going to bring in anything, remember, you are responsible for your own equipment and cannot blame hospital staff if you don't leave with what you brought in. If someone is being rushed into hospital, chances are you've gone without any equipment. You've probably gone in by ambulance, in fact. A person being discharged from the emergency room may be required by some hospitals to bring in a wheelchair or to be in a wheelchair up to the car door, and hospitals that do have this policy often have transport chairs for this purpose. Another question I've had today involves a piece of adaptive equipment called the U-Step walker. There is an Ontario distributor for this. They are called Bay Green Home Health. Their telephone number is 905-771-0010, and they are located at 8 Green Lane in Thornhill. Again, there are many considerations to take into account when purchasing any type of mobility aid. In general, it is always strongly recommended that a physiotherapist or an occupational therapist do an in-home assessment with the equipment. There are often nuances of equipment that may make using it in your home more difficult, such as your particular type of flooring, the size of your halls, placement of doors, and configuration of fixtures, such as in bathrooms. This can, in general, make one piece of equipment less useful to one patient over another's personal situation. So again, going back to the question about the U-Step walker, the original walker was heavier and larger than a standard walker, so care partners had greater difficulty putting them into the car. The newer one is lighter but features the same smaller caster wheels, which allow for a freer range of motion and may make it much easier for people with Parkinson's to turn with. Conversely, the smaller wheels may make it difficult for some people to use outside of store or home settings that are bare-floored. It may be more difficult for some to manage over curbs, gratings, and carpeting. The U-Step walker does, however, have some amazing features and options that are not found on other walkers, such as the reverse brakes that have to be continually gripped in order for the wheels to go. Other walkers have to be gripped in order to stop, but the U-Step walker has brakes that if you let go, which can be helpful in freezing situations, the walker automatically stops and does not roll ahead in front of you. Conversely, again, someone has to have the hand strength to maintain a grip. An optional adjustment or adjustable laser light, which can be added, can also be useful for some people with freezing issues. Again, currently, Bay Green Home Health is the Ontario distributor for the U-Step walker. We know they have been in the process of applying, to the Assistive Devices Program, or the ADP, to get the U-Step walker recognized as a necessary piece of equipment, which would potentially make it eligible for subsidy by ADP. For those of you who are unfamiliar with ADP, it is a government program which subsidizes up to 75% of a approved piece of equipment, which is prescribed by a licensed therapist. You need approval before purchase, so it's up to you to do your homework on this. Now, I hope you're all sitting down, because you need to understand something. The U-Step Walker 2, that's the second version, costs $824 US. This makes it even more important for those who are considering purchasing it to try it for themselves in their own homes before investing in the product. Like any other piece of equipment, there are pros and cons for the U-Step, depending on an individual situation, and it may not be appropriate for everyone living with Parkinson's. Sadly, too many people rush into purchasing a piece of equipment without the input of a physio or occupational therapist, only to discover that it is not really appropriate for their safe use. This can mean This can mean a very expensive knick-knack cluttering a corner, or even worse, can contribute to a greater risk of fall when it has to be stored and not used in the home.
And if I may, just to keep this on topic, a question just came in regarding your discussion on walkers. Could you use CCC for this service? Perhaps
Okay.
referencing assisting moving them, or perhaps just in general regarding their availability?
Okay. I'm not sure. When you say about CCAC, I don't believe that CCAC would provide this type of walker. They will help you to get a physiotherapist or an occupational therapy assessment, that's for sure. So that's where the CCAC can come into to be of great benefit. You can request the Community Care Access Center, which is what CCAC stands for, to send in a physiotherapist or an occupational therapist. Most of them do have are registered so that they can apply for you on your behalf to the Assistive Devices Program with respect to regular walkers and all kinds of other equipment. I hope that answers the caller's question about this. Another question that I received is from a lady who is actually dealing with her mom right now, who is in hospital. She has been finding it difficult to get the nurses to bring the medications half an hour before her mom's meals because, as she states, the nurses are usually very busy with other patients. Usually, however, she says, when she tells them that protein is in direct conflict with her mom's Parkinson's medications, she can get them to act a little more consistently with this. And she goes on to say, it seems every day we are training a new nurse on the importance of the timing of the medication. And again, this just speaks to the reality that I talked to during my presentation. Whenever you go into hospital, you have to understand that you will have to educate and teach every new person who is involved in your care. That unfortunately is just the way it is. But and you cannot expect one healthcare professional, one hospital staff member to pass on what you have said to another hospital staff member. So basically, you will sound like a broken record. But in order to get the care you need, there just is no other way around this. I don't know of a better way to get the message across, except you just have to continue to be an advocate. And thank you for this individual who did ask this question and make these comments, because it really supports me and what I have been trying to get across to you today. Another question are, what are the current odds of getting out of the hospital once you are admitted? I believe that, depending, of course, again, on the reason for the hospitalization, I believe that the odds are good. But again, this depends on many, many factors. It really depends on how well you are before you go into the hospital, both physically as well as cognitively. I think it depends very much, again, on your teaching of the staff, because obviously if the staff do not give you your medications on time, you're going to go sort of back to basics with your Parkinson's. Your Parkinson's symptoms will definitely get worse. That will also contribute to the length of time you will have to be in the hospital. There's just a myriad of contributing factors for being able to come out of hospital. I would not want to say that I don't know the actual statistics, but I believe that given all of the factors, and especially your preparation whenever and if ever possible to go into hospital, your odds would be better than average. But again, it's an extremely individual situation. That's the reality, unfortunately. I also have a question from a caller who said, you said that recovery time for surgical procedures would be longer for someone with Parkinson's. Would that apply to recovering from a fracture as a result of a fall? I believe the answer to that question is, again, yes. And when I say that, do I mean that the actual fracture in and of itself, the knitting of the bones together, would take longer? I would say no. I don't think that would take longer because Parkinson's doesn't affect bones. But what it does affect, I believe, is that a person who is in hospital as a result of a fracture, it will take you, quote unquote, longer to get back on your feet. The rehabilitation process post-surgery after a fracture will have to definitely, I would say, take longer because you will be slower to move. It's not like the surgery will take away your Parkinson's symptoms. Wouldn't that be nice? But you will definitely move more slowly. You will be more rigid. Once again, if you don't get your medications when you're used to taking them, that will interfere in your rehabilitation process. But I would say that it would be realistic to expect that your rehabilitation after a fracture, so that's not the setting of the bone, but literally getting back on your feet, I would believe that would realistically be able to be expected to be a bit longer. So it's about 10 to 1 now. As far as I know, at the moment, there aren't any other questions.
Another question. I'll note that a point of clarity came in for us on the Walker discussion.
Good.
CCAC.
Okay.
And you may be able to speak to the comment. We may just leave it at this.
Sure.
But it says, CCAC will visit and discuss all the products available.
Yes.
It can also start the discussion about long-term care for future needs, and we'll do an assessment to start that process.
Absolutely. Yeah, that's for sure. There's no question. During one of my talks, I will talk about home care support, including CCAC, which will, of course, come into play during, after a hospital stay, of course, as well as at other times as well. But CCAC is your initial contact for any kind of home care, and are also your window into, also your window into any form of long-term care. I just want to say one more thing, and that is around your discharge planning. Again, it is important for anyone in hospital to have a proper plan for discharge. There are discharge planners that will be involved with your hospital stay right from the beginning to the end. It is their job to ensure that you get the correct discharge planning in place. However, once again, it becomes your job to educate even the discharge planners about your needs and the fact that while, depending on the surgical or medical procedure that you've been hospitalized for, the average individual may be able to go straight home right afterwards. But again, that may not be possible for you, and you need to advocate for yourself about what your needs are so that you don't end up at home, find out that you can't stay home because your needs are too great, and once again become part of what I call the revolving door syndrome, where you'll have to go back into hospital again as a result of incorrect discharge planning. So one last thing for today, and that is that I am currently in the process of writing an article for the next Livewire. That should be coming out, I believe, at some point during the summer. Is that right, John? The Livewire, next Livewire?
Yes, it should probably be right around the start of August.
Oh, okay. Okay, fair enough. At any rate, I am in the process of writing an article for the Livewire on hospitalization. So a lot of the things that I've mentioned today, I'm also planning to mention in my Livewire article as a follow-up, so please keep an eye out for that. So thank you very much for listening today. I hope this has not all been too complex and confusing. Hospitalization, in my opinion, is a very complex topic, and there are many, many things to be considered, but I hope at least this will be able to enable you to start the discussion, should hospitalization be necessary. Thanks for listening. Take care, everyone. See you in July.